medication overuse headache is a headache in people who have a primary disease like migraine. And it's defined by people who have more than 15 headache days per month and take on more than 10 days per month specific medication for the treatment of migraine attacks like triptans, or they take simple analgesics like ibuprofen on more than 15 days per month. There is another entity which is called medication overuse. So for example, if you take on 11 days triptans, but you have headache only on 11 days, it's not medication overuse headache. It's only medication overuse. So we have three kinds, if you want. Medication overuse, chronic migraine without medication overuse, and then chronic migraine with medication overuse. Yeah, the issue is that people who have medication overuse headache and chronic migraine are difficult to treat. And the major problem is the paucity of results from randomized trials. So until recently, we had only scientific evidence for topiramate and onabotulinum toxin A that they are effective in people with chronic migraine and medication overuse headache. This has changed with the monoclonal antibodies against CGRP or the CGRP receptor, because all of these studies had subgroups of patients in the chronic migraine trials who had medication overuse, and they obviously also had a benefit from the monoclonal antibodies. Yeah, the PROMISE-2 trial was a trial with about 1,070 patients with chronic migraine. And there were three treatment groups: placebo, 100 milligrams of eptinezumab IV, or 300 milligrams given IV at the beginning and after 3 months. And in this trial, eptinezumab was clearly superior to placebo for the primary endpoint, which was the reduction in migraine days per month. Now, about 40% of the patients, 431, had predefined medication overuse headache. So the doctors who participated in the trial were really trained to identify these patients. And very importantly, these patients also clearly had a benefit from eptinezumab over placebo. Let's say the good news is that we have now evidence that this drug works in chronic migraine, and it works in the subgroup of patients who are most difficult to treat, namely people with chronic migraine and medication overuse headache. The good news, in addition, is that many of these patients, about more than half of them, after 3 months would no longer fulfill the criteria for medication overuse, which is also good news. Now, there are a few unanswered questions, and one important question is, what happens with these patients when you terminate the treatment? So what we would need basically is a trial which treats patients for 6 months and then randomizes to placebo or active drug and see, is there something like a rebound phenomenon? So are patients who are getting really good getting worse again, and what is the percentage? So what we know from onabotulinum toxin A is that half of the patients remain stable and good, so they don't need any treatment anymore. But the other half, they will deteriorate when you stop the preventive treatment, and there you have to continue. And this has not been studied for the monoclonal antibodies. We know that these drugs are very well tolerated. So in contrast to the traditional drugs we had, like beta blockers, flunarizine, valproic acid, topiramate, amitriptyline, the major problem with these drugs was not efficacy, it was basically side effects and people terminating the treatment because of adverse events. And the big advantage is that the monoclonal antibodies have almost no side effects. But CGRP has a reason why it is in the body and in the brain. And the reason is it's a very important drug which works on blood vessels in emergency situations. So, for example, when you have a stroke, when you have an acute coronary syndrome, when you have Raynaud's disease, when you have peripheral arterial disease, and we have no idea what happens if in the unlikely event that someone has such a vascular event and he has a monoclonal antibody on board. So this is basically totally unknown whether this would have a negative impact. Another example is subarachnoid hemorrhage, where you can have vasospasm. And we know that CGRP prevents vasospasm if it's released. So these are totally unanswered questions, and we will need to observe thousands and 10,000s of patients until we know whether this has a detrimental effect or not.